Okay, perfect. So thank you for having me. I'm Yossi Schwartz, and I'm the medical director for the blood banks, both in West and Morningside, and also have some system role for quality assurance for transfusion medicine. Before I came to Mount Sinai, little than a year ago, I was at Columbia for many years. So what I wanted to do is to, I was asked by your chief to give a little bit of scenarios, and I tried to do that. And with those clinical scenarios, I would like to give you the important calculations that done blood banking, and not that you really need to do those calculations, but basically those cases and those calculations will make you understand some of the work behind the scene and why sometimes somebody will say in the phone to you, there'll be some delay in processing of the blood, or there'll be some time, take some time to get this, or how much do you want? So I thought through this conversation, we can have a little more understanding of the intricacies of transfusion medicine. So we'll talk about 5 different scenarios: platelet refractoriness, antigen frequencies, cryo and factor, and NTID raw game calculation. Again, each one of them relates to a clinical case that, happens actually relatively commonly. So the first case will be platelet refractoriness, workup and calculation. And the case that we are looking at is a 40-year-old male with no diagnosis of acute myeloid leukemia. He was admitted for induction chemotherapy. 2 weeks later, he has experienced pancytopenia secondary to the myeloablation. In addition, he's febrile, possibly septic. His hematocrit is 18%. He doesn't have any white count due to the myeloablation. His platelet count 4,000. He's oozing from the central venous catheter, and platelet filtration is requested. And it's obviously, those of you who rotate on internal medicine and in hemonc, it's a relatively common scenario. However, he has received multiple platelet products, but no longer seems to be responding, as evidenced by minimal elevation in post-transfusion platelet counts after the transfusions. So what can be done in this situation? So first, as a general background, we know that there are factors, a few factors associated with platelet transfusion refractoriness. In the big groups, is either on non-immune factors or immune factors. You guys are very familiar with non-immune factors such as patient with fever, with sepsis, with splenomegaly, DIC, patients that are getting some drugs that will cause some platelet refractoriness or thrombocytopenia, so vanco, etc. And there are products, factors that relates to blood banking, some storage duration, the dose in the platelets, ABO compatibility, but those are less critical for our discussion today. The second big bucket is immune factors. It's either autoimmune or platelet antibodies, which you're all familiar with ITP scenarios, or if we have allo antibodies, which is probably in this case, such as HLA antibodies or human platelet antigen antibodies. And again, like in our case, most commonly occurs in patients who are chronically transfused, such as hemonc patient, and usually due to HLA antigen exposure. So the difference between when you have refractory circulation platelets, either non-immune or immune, is really what the kind of the response to the platelet. So non-immune causes in the blue bar on the graph associated with initial increase in platelet count, followed by inadequate 24 hours post-transfusion platelet count. In immune refractoriness, you don't even have this minimal increase, even in the first hour after the transfusion. And that's make it easier for us, not for the patient, but for us to make the distinction and to decide if that's immune or not immune. And of course, in regular life, one should expect that if you give a transfusion of 1 unit of platelets, we only use at Western Morningside single donor platelets, they should raise an average adult platelet count by 30 to 60 per 1,000 per microliter. But that's really the ideal situation. Obviously, in our case, it doesn't really happen at all. So there are two methods to calculate platelet refractoriness. It's either platelet recovery percentage over the correct count increment. The platelet recovery is basically you take about the absolute platelet increment, platelet count after minus the platelet count before, times the blood volume, divide the platelet dose in the bag. And in order to have adequate response, you have to have between 1 hour after transfusion, more than 20%. And if you go to 18 and 24 hours, you want to see more than 10%. The second refractorin that we commonly use in blood banking is the correct count increment. Once again, you take the platelet count after minus the platelet count before, you multiply the body surface area, divide by the platelet dose, and again, you should see if you take a count between the first hour after the platelet count transfusion, you see more than 7,500 or more than 4,500 if it's 18 to 24 hours. So the important part for you, if you encounter this patient and you call us or you call me, I would say to you, get me a post count that should be obtained in a very close proximity to the transfusion, 10 minutes to 1 hour. And here is just an example of those numbers. A patient, percent of platelet recovery, he had 50,000 platelets after, 3,000 before, the blood volume of 5 liters, the platelet dose in the bag is 3 to the 11, making the MEG, it's 20%. So that's really kind of a good response. That's what we commonly, or at least what we do now routinely in many hospitals, if you want to see if there is a response. Once again, this is an example of a calculation. Platelet counts before 3, after the transfusion 15. The body surface area is 1.8. Platelet dose in the back 3 to the 11. If you make those calculations, like in the equation, you get to 7.2 or 7,200 platelet count rise. And as I said, in order to have adequate response, it has to be more than 7.5 or 7,500. And if you have 2 CCIs less than 7.5, you can say that the patient has immunorefractoriness based on this count, 10 minutes to 1 hour. So if we encounter this patient, like in this patient, we have already made the decision, this is immunorefractoriness, what can we do for the patient? Basically, for immunorefractoriness, we can do something in the blood bank side or in the ordering side. If we decide the patient has immunorefractoriness, we test for HLA, we send it out, at least in Western Morningside, most of the hospitals do. And then based on the antibodies we get from our suppliers, we can actually get different platelets or unique platelets for this specific patient, either HLA identical, HLA compatible, or cross-match negative platelets. And with this, we can make sure that the patient will respond to platelet transfusions. Let's move to the second scenario. In this case, we're talking about antigen frequencies, antigen negative red cell calculations. So let's talk about, again, the relevant case. And I called it patient with antibodies. What you guys many times will see on Epic screen, or when you call, while there is a delay, the blood bank will tell you there is a positive screen. So this is a 55-year-old male with chronic lymphocytic leukemia, present with history of fatigue, jaundice, and dark colored urine. 3 weeks ago, he received a transfusion of 2 units of red cells at an outside hospital for anemia. His hemoglobin is 7. DAT, what's known as Coombs test, is positive. The blood bank tells you that the antibody screen is positive, and the antibody identification in the blood bank, we have to do antibody panels whenever there is an antibody screen positive. The patient has an antibody to one of the red cell antigen called JKA. The red blood cell availability might be delayed, especially if they are going to identify additional antibodies. What's going on and how bad can be this delay? So first, just again at the background, this slide showing you the generalized frequencies of the major blood antigen in Caucasian Americans. And why is most of the data known about Caucasian Americans? Because traditionally, this is a data for blood donors, and traditionally, minorities were not blood donors or didn't come in masses, and there is a lot of effort in the communities, the Black communities, Hispanic communities, to encourage donations. But most of the data of frequencies in the literature is Caucasian. But again, for the most part, it's okay to go by those numbers. You don't need to remember it, but you'll get to understand that that's behind the scene of the blood bank. And if you just want to remember a rule, most of the antigen frequencies are somewhere around 70–80%, including what this patient adds as JKA. And we'll talk about in a second. So key concept, when you have a patient that has an antibody, then the patient must receive red cells that are antigen negative of those antibody identified. I hope you understand this is clear. The patient is antibody in the plasma. You must give them antigen negative. Otherwise, the antigen of the red cells will react with the antibody the patient already developed. So the patient must receive red cells that are antigen negative of the antibody that are identified. And based on those frequency, you can figure out how easy or hard it's going to be. So this obviously required the knowledge of the frequency in the antigen equation, like we showed in the previous slide. And then the likelihood of antigen negativity is equal 1 minus antigen frequency. So for example, in our case, the patient had an antibody to JKA. JKA antigen frequency in the population is 77%. Thus, 1 minus 77, 23% of the donors will be antigen negative for JKA. Not that bad to get to find 25% of donors that will be okay for these specific red cells to give to this patient. Of course, once in a while, we have, especially if you have a patient with sickle cell disease, they develop multiple antibodies. Then it becomes even more problematic because you have to calculate the antigen negativity rate by multiplying each individual. So if you want to see what's the likelihood of finding antigen negative red cells for a patient with JKA and CAL antibodies, the JKA frequency, as we said, 75%, 77. So 0.77, antigen negativity will be 0.23. The CAL frequency in the population is 9%. So antigen negativity for CAL will be 1 minus 0.09, 0.91. So if we have a patient that needs to get CAL negative and JKA negative, we have to multiply the 0.23 and times the 0.91. It's 0.2093. Again, still not that bad. 21% of the donors will be negative for both JKA and CALs. But you can see the more you add, you have less of pool of donors of red cells to look for. A practical tips, it only works those calculations that are independent of each other, like in this case, JKA, CAL, or what we call FYA, Duffy, and CAL. Those are different blood groups. It doesn't work for parallels. So if you have a patient that has both Duffy A and Duffy B antibodies, likelihood of finding negative red cells for those two is much lower than multiplication of the antigen negativity for each one of them. So if we do the regular formula that is told you above, but we'll have to do 0.33 times 0.2 is 0.06 because Duffy A negative is very rare in Caucasian. Again, same is for JKA, A and B. So the rules of the multiple antibodies calculation is for alleles that are not paired. So sometimes the questions will be, how many units will the blood bank have to screen in order to find these antigen negative units? So the number of units to screen will be the number of units desired divided by the antigen negative frequency. For example, if the technologies were to randomly screen type O red cell inventory to find compatible units for Duffy A, CAL, and JK antibodies, how many units will have to be screened if you order two appropriate units? If the antigen frequency has 90, 35, and 30, respectively, so you take 2 divided by 0.2 times 3.35, 0.3, we have to screen 21 units in order to find those units. This is a lot of work. Of course, if you order 4 units, then if you put 4 in the equation, the blood bank will have to screen 42 units theoretically in order to find those antigen negative units. This is, of course, many times a blood bank in West and Morningside not visible. So we will order those units from outside, from our supplier in your blood center. Again, you have to calculate the extra time of travel. Let's talk about cryo fibrinogen calculation. Again, a relevant case. This is a 30-year-old male, a female is currently undergoing series of therapeutic plasma exchange for optic neuritis. Her current fibrinogen level is 75 milligram per deciliter, and her hematocrit is 30%. Her weight is 80 kilograms. She needs to have fibrinogen level. This is just theoretical number. I chose 150 milligram before the next apheresis. We usually require 100, but that's just for this argument, for this calculation. I put 150 milligram, the required level of fibrinogen. How many bags of cryo, what the call name, the cryoprecipitate antihemophilic factor, common as we call it cryo, does she need in order to accomplish this? And of course, just as a background, we all remember that cryofibrinogen, cryo has fibrinogen, factor 13, factor 8, von Willebrand factor, fibronectin, but it is the product of choice fibrinogen replacement because therapeutic doses of fibrinogen may be provided at much smaller volume than with plasma. There is enough fibrinogen in plasma, but if you want to consider small volume, only for fibrinogen replacement, cryo is the product of choice. So the formula to calculate the number of cryo bags needed to raise the fibrinogen from initial to final is the number of bags needed is plasma volume in mLs times fibrinogen final minus fibrinogen initial times divided by fibrinogen content per unit of cryo. You can see most of blood calculations takes the consideration the volume of the plasma volume of the patient, the values before and after, and what's in the bag we're given. Some practical tips: the FDA only require a minimum of 150 milligram per fibrinogen in each individual bag of cryo. In reality, each bag contains close to 250 milligram fibrinogen. Thus, we use 250 milligram for this calculation. And again, just to make it easy, I put 100 the equation. It's just to show you this is very easy to make all the numbers work correctly. In real-world situation, the above formula is rarely used because typical cryodosing, now we have actually a pre-pool cryo. You get one dose that have 5 or 10 units. So we kind of solve the issue for you. But again, if you go to places that still use individual cryo, it's easy to know this calculation. And this is how we'll do it. So here's the formula we just said. And again, the first step, we need to know the patient plasma volume. So on the left are estimate blood volume calculations. This you don't need to know too much, just we use, and it's true for plasma exchanges, 70 for an adult, 70 cc per kg. So is an estimated blood volume. So if this patient is 80 kilos, 70 times 80, 5,600 ml, that's a plasma volume, blood volume. Plasma volume is blood volume times 1 minus the hematocrit. In this case, hematocrit was 30. So her plasma volume is 5,600 times 1 minus 0.3, 3920 will be the number that we'll put in the equation. So here's the equation, 3920 for the plasma volume. We want to get to 150. We started with 75 and we put 250 milligram fibrinogen in the bag contact of a unit. So you can see that the formula will give you 12 bags of individual cryo. Once again, these days it's a theoretical calculations, since now you can order 1 dose or 1 unit of cryo from a blood bank, and you can already get 1 pre-pool that already contains 5 or 6 bags. So you really don't have to worry about individual bags anymore. Okay, so let's talk about a little bit about factors calculations. Again, it's at Mount Sinai Morning Southwest, where you guys are now in residency. The factors are coming from the blood bank, and that's why we talk about it today. However, in many blood banks, in many institutions now, the factors have moved to pharmacy because those are really pharmacological agents these days. So just go over that because at least for us, it's still coming from blood bank. So again, the relevant case, 50-year-old male with history of severe hemophilia A is admitted to the hospital for a scheduled cardiac bypass surgery. The next day, he takes prophylactic factor 8 at home 3 times a week. The patient cardiac weight is 60 kg. His factor 8 level is 20%. Hematocrit is 40%. What is the dose of factor 8 you recommend prior to this operation and then for maintenance? So the amount of factor 8 can be calculated as following: plasma volume times the goal of the factor minus the initial level you have, or simply, put it simply, plasma volume time increase desired. After administration of the initial dose, factor 8 shall be given for maintenance, the half of the initial dose every 8 to 12 hours. In some instances, a quick common rule of thumb for factor 8 dosing is 1 unit per kg of the factor 8 will raise the factor level by 2%. However, I'll share this way may lead to over or under dosing factor 8 depending on patient hematocrit. So let's look at some calculation for this specific patient. This patient estimated total blood volume is, as we said, 70 ml per kg times 60 kgs, 4,200 mLs. His plasma volume, 1 times the hematocrit, 1 minus the hematocrit is 0.6 times 4,200 mLs, 2520 is his plasma volume. Given this is going to have CABG, his factor level should be raised to 100% because this is really a major surgery. Thus, initial dose of factor 8 is the plasma volume 2520 times 100 minus 20, where we started when we were to go. So you need to order 2016 international unit. The maintenance dose should be half of this, 1008 international unit every 8 to 12 hours. If the rule of thumb of calculation was used, the initial dose would be 60 kilo times 100 minus 20 divided by 2, 2400. So that's overestimation. Thus, we really want to stick with the formula because it gives us the exact amount that we need factors. Similarly, you do have the calculation for factor 9 dosing. The only difference is that factor 9 has both intravascular and extravascular distribution, so the initial dose should be double. So the formula for factor 9 replacement is plasma volume times factor 9 goal minus factor 9 initial times 2. The frequency for factor 9 maintenance should be every 18 to 24 hours. Again, there is a quick common rule for factor 9 dosing. 1 unit per kg will raise the factor by 1%. But again, similar to factor 8, it may lead to over and under dosing. So I'm not using this. It's just that, it's written in the literature. So this is an example for patient with factor 9. Then the calculation based on the previous slide, initial dose is the 2520 plasma volume times 100 where we want him to be minus 20% where he started with the level times 2. So you get to 4,032 international unit of factor 9. The maintenance dose will be half of this, 2016 international unit every 18 to 24 hours. And again, the rule of thumb would get you to 4,800, and that's why I don't recommend this rule of thumb. Continue with this case. Approximately 10 years after CABG, this patient was found to develop a factor 8 inhibitors. At 100, the inhibitors levels are with the Bethesda units, 120, a relatively high level of inhibitors unit. He is now admitted to the hospital with viral myocarditis in tamponade. In the emergency room, lab showed PT of 15 seconds, PTT of 69, with the norm goes to 26 to 68, and fibrinogen of 250. His weight went up in those 10 years to 100 kg. The ET physician asked for advice regarding the type of dosage of blood product and oil derivatives for this patient. The patient inhibitor is very high, 120 Bethesda units, as we said. Thus, it's unlikely to respond to superdose factor VIII. Therefore, we need to think of a bypass agent that should treat his bleeding in addition to surgical intervention. Available bypass agent is recombinant factor 7A, Novo7, as you might know it, or factor VIII inhibitor bispecific agent, 5-by in short, again, used relatively common on our campuses. Those are the dosing for those 7A for Novo7. So you can see there are different literature and different doses depend on indication. If you have a patient with congenital factor 7 deficiency, the dose is 15 to 30, there's a typo here, microgram per kilogram every 6 to 8 hours. Congenital factor 8 and 9 deficiency with inhibitors, which is our case here, 90 mg per kilogram every 2 to 3 hours until bleeding stop, or other indications that are approved that are not for our cases today, Glassman and acquired hemophilia. So based on this table, the patient should receive 90 mg per kilogram times 100, because that's the patient weight, 9,000 microgram or 9 milligram factor 7A Novo7 every 2 to 3 hours, because that's the half of this drug until bleeding stops. The other bypass agent is FIBA, and FIBA may be used instead of Novo7 in treatment congenital factor 8 or 9 deficiency with inhibitor. It is a plasma-derived product. The initial dose of FIBA is often based on the severity of the bleeding. For mild bleeding, a dose of 550 international units per kg may be sufficient. For severe bleeding, dose of 75 to 100 are often chosen. And since there is a risk of thrombosis, more than 100 unit international unit per kg is rarely used. The maximum recommended dose for FIBA is 200 international per kg per day to decrease thromboembolic risk. And the frequency for FIBA is determined by the bleeding type, can be between 6 to 12 hours. Lastly, let's talk about PCC, or what you guys are familiar with, Kcentra, as the common name, dosing. So this is again a relevant case. 65-year-old male admitted to the emergency room with intracranial hemorrhage. He's on warfarin for stroke prophylaxis because of atrial fibrillation, and he has a multiple other medical problems. He weighs 120 kg. His INR is currently 8.5. The neurosurgeon requests the blood-brain resident suggestion to reverse the effect of warfarin in this patient prior to emergent surgery with 4-factor PCC Kcentra. What should be the recommendation except saying, I don't know, I wish it would be in pharmacy. So 4-factor PCC Kcentra, it is FDA approved for emergency reversal of warfarin. In addition to vitamin K dependent coagulation factors 2, 7, 9, and 10, 4-factor PCC also contain protein C, protein S, which are natural anticoagulant. And this is the dosing of the drug based on the pre-treatment INR. And you can see it goes from 25 international per kg up to 50. And additionally, but there's also a maximum cap on the dose of Kcentra. And additionally, since the half-life of factor 7 in 4-factor PCC is short, and factor 7 levels of significant effect on INR, IV vitamin K is always recommended to give along with 4-factor PCC to restart liver synthesis of the coagulation factors. The patient is bleeding, and his pre-treatment INR is 8.5. Thus, he will receive, based on the table from the previous slide, he will receive 50 international units per kg to reverse the warfarin effect. However, as we said, there is a maximum dose. Since he weighs more than 100 kilograms, the recommended dose should be 5,000 international units for 4-factor PCC. Again, we just said 10 milligram IV vitamin K should also be administered. And lastly, Let's talk about ROGAM or anti-D calculation. And we are not going, since we are not doing obstetric LND, we'll exclude those usage of anti-D. So this is the last case for today. This is a 15-year-old girl with a new diagnosed ITP present to the emergency room. She has a substantial nosebleed, blood type is A, Rh positive, CBC reveals hemoglobin of 12.5 and a platelet count of 5,000. The patient has not had a splenectomy. The decision is made to treat with intravenous Rh immune globulin, IV RHIG, and the blood bank is called to have calculated the appropriate initial dose. A body weight of 70 kilograms is provided to this patient. What is the initial dose that should be administered? So Winro, just a generic or brand name, is an IV RHIG. It's FDA approved for acute and chronic ITP in Rh positive patients who have a spleen. Why is it important? Because although the exact mechanism why it works here, it's been proposed that the anti-D will be bind to the RHD antigen on patient red cells. There is immune-mediated clearance by the reticuloendothelial system. So there is a competition for clearance site on the spleen with the platelets are being destroyed for this ITP. Thus, while the spleen is now busy with this kind of the induced hemolysis we gave him with the D, there is a decreased clearance of antibody-coated platelets, and the platelet counts will go up. So it's kind of competitive. We, on purpose, induce hemolysis on a D-positive patient. We give an anti-D, we'll go to the spleen, we compete with the platelets being destroyed by ITP, less platelet were destroyed, the platelet count will go up. Those are the according to the package insert of the Winro, those are the doses that we need to give the patient. It's important to remember that the package can become as 50 microgram per kilogram, but also as international units per kg. And it's important that the conversion, because it's on the box in the blood bank, sometimes it depends on where you get it from, either international units or microgram. So 1,500 units will be 300 microgram, et cetera, et cetera. Again, you don't need to know that, but it's just important to figure out when you write the dosing. So this is the case we said. She is in the ER with low platelet count. She is a Rh pos, and she does have a spleen, so she's a candidate for RHIG. And using the above formula, we'll say that we want basically from this graph of the dosage from the manufacturer, her hemoglobin is more than 10, so we'll give her 70 times 50, 3,500 microgram, or 17,500 international units. Just short. Patient, when you give RHIG to a patient should be monitored for at least 8 hours with the occurrence of adverse event. Don't forget, we are inducing hemolysis, so there might be some DIC. Intravesical hemolysis is very rare, it just happened. The FDA recently placed a black box warning indication that intravesical hemorrhage leading to that has been reported for when using Winro for the treatment ITP. Thus, the patient needs to be monitored closely with signs, symptoms, and lab evidence of intravesical hemorrhage in the healthcare setting for at least 8 hours. We need to do a dipstick analysis to monitor hemoglobinuria hematuria. That's baseline 2 hours, 4 hours, and before the end of the monitoring period. A CBC should be ordered after the 8 hours of observation to assess the hemoglobin level. Again, just to remind you, we kind of induced hemolysis by ourselves. Usually it goes down very little, a gram per deciliter, but we just have to be mindful of that. There is one unique scenario that I would just want to mention for last. This is something very rare, but it just, it can happen. This is a 20-year-old female presented with ITP, blood count is 10,000, and she's actively bleeding. Blood record reveals she's a blood type O negative. They give one dose of platelets, and there are no Rh negative platelets in the blood bank. So the blood bank is issuing 1 unit of Rh positive platelets. If RHIG should be given after transfusion, Rh positive platelets to a Rh negative patient, how many SDP unit will 1 vial of ROGAM cover? Let me just stop here to say that you don't need to do that. If you will call me, I will not recommend you, because the apheresis platelets that we have in the blood bank, the SDP, has very, very, very little red cells, less than you can see here, 0.0004 ml on average. So for me, the chance for induced immune reaction is almost doesn't exist. In the good old days, when we used whole blood derived platelets, it was 0.5 ml on average. But again, it's still very low. But just for theoretical consideration, if one wants to give ROGAM after transfusions as Rh positive platelets, we have to remember that each vial of ROGAM can cover 30 ml of whole blood or 15 ml of red cells. As a conservative number, we assume each single donor platelets contain less than 2 ml of red cell. So as a minimum, 1 vial of ROGAM can cover 15 ml of red cells, less 2 for each unit, 7 units of SDP. But in reality, since I said there's 0.004, each vial of ROGAM may cover way more many of SDP, again, if you decide to give it. But I don't necessarily do that if we need to give Rh-D positive platelets to Rh-D negative patients. So with that, it's a lot of information. I always said that blood banking easier if it was coffee, but it's not. So we have to take all those, remember all those things for ourselves. Just wanted you to be aware and to be cognizant, and happy to take any questions if you have.